Can you guys all hear me? Yeah, okay. Good morning. Okay, we're going to get started if everybody can find their seats. This is the worst part of my day. Good morning and welcome to Birdshot Day 2024. My name is Christine Griffith. I am a patient here at Wills Eye Hospital. I'm also the president and a founding member of Birdshot Uveitis Society of North America. First of all, I'd like to thank everybody for coming today. Our registration showed that we had people from 13 different states, 3 Canadian provinces, and the United Kingdom. So very nice turnout from all over. It shows the representation of who we are as patients. Next, I'd like to thank our exhibitors in the lobby. Many of you have already seen. We have 6 vendors, exhibitors, from Alamira, Blind Institute of Technology, Enhanced Vision, Essenbach, Orcam, and Vision Link. You all received a card. If you did not, you can go and it has 5 spaces. Get it checked off once you visit them, get an initial. We have a lot of really cool giveaways. There's some t-shirts, some soccer balls. Just go and have a little chat with them. They're here to help us find out some information that might be beneficial to all of us. I'd like to thank our speakers and our presenters for the day. That should have come first, but we wouldn't be here without you. You're really why we as patients are here to learn tools and tricks, to learn more about our disease, to learn about the future of research and how we can manage. So thank you for being here. We appreciate your time, and we look forward to asking some good questions. Also, we have in the back, I'd like to thank, we have some really nice items that we'll have for raffle as well, or donations. Many of them are created by our fellow Birdshot patients. On our Facebook page, we like to highlight the things that patients do despite being diagnosed with Birdshot. And many of these talents are when something that a patient might have already done prior to being diagnosed or post being diagnosed. They pick up a new talent or skill. There's photography back there. There's handcrafted silver jewelry. There is quilting. So be sure to check it out. I'd like to thank everybody that donated to those. It's really a wide variety of talents. And finally, we have in the lobby our sponsors for today. There's a huge bulletin board out there. We have our corporate sponsors, Alamira, Wawa gave us the water bottles. We have plenty. Please grab one today. Grab one when you go out the door. Stay hydrated tonight, or if you're leaving to go home, grab a second one. They gave us plenty. And also to Wills Eye for using the auditorium, and to our friends of ours, Josette, I'm going to blank now. Environmental Resolutions, Inc. They also sponsored us as well. But please check out the bulletin board. There's also individual sponsors on there. You might be sitting next to one of them as well. So thank you to all of them. So this is kind of a full circle moment in a way. 5 years ago, 6 years ago, after not being able to attend a similar event in the United Kingdom put on by our sister organization, and Annie Folkert, who is here today and will speak, Annie strongly nudged us, Americans and North Americans, to start something of our own. So upon her nudging, and specifically kind of saying, how about somewhere between Baltimore and Philadelphia, I believe it was in the messaging, I had an appointment with Dr. Dunn about 3 weeks later, and I walked in and said, would you do something with me if I organize it? And so what ensued was a similar event to today, much shorter, much smaller, and it was great. Intended to keep doing this, and then the pandemic came. So I had only up to that point met 2 other patients, And so I reached out to the women that I had met and some men and asked, would you guys be interested in starting a nonprofit where we could support patients, where we could raise funds for research, and where we could bring awareness to our disease. And so the next year, we met weekly on Zoom, weekly. Many of the people that are founding members of the board are here, and as well as people that just helped out in the beginning to help us figure out the legal paperwork, gave us the financial seed money to start everything. And here we are today. To date, we have donated just short of $30,000 to research, and we have held almost 15 online Zoom support meetings where we talk about just about everything. And today, this is our biggest in-person event, our first and our biggest in-person event. So thank you all. And to get us started, a couple other things, I apologize. The exhibitors, you all received the cards, so be sure to get that checked as well. And be sure to ask questions. And there was something else I was going to remind you, but I'm forgetting now. If you need any help, I think you've all met one of us. If you have any questions, please grab one of us. But to get us started, I will introduce the person that diagnosed me 13 years ago and is the director of the uveitis department here at Wills Eye Hospital and a professor of ophthalmology at Thomas Jefferson University, the Sidney Kimmel School of Ophthalmology. Dr. James Dunn.
So a brief disclosure here. I remember when Christine talked to me, came in and said, I'm interested in putting together this discussion about ophthalmology and try to bring in a bunch of patients and lots of different sort of resources that patients can start to look into. And I remember she said, would you be interested in taking part in that? And I remember that my immediate answer was no. But those of you that know Christine know that she's very persistent. So by the end of that visit that day, I had agreed to do it. And the first meeting was great. As she said, it was much smaller than this. But it was a really nice introduction to that sort of approach of getting patients involved, making patients aware of the resources, making physicians aware of the need among patients who have birdshot. And I'll talk about a number of those things as we go on. Another point to make, I'm definitely not going to talk for 70 minutes as they have allotted. So those of you that were panic-stricken when they saw that, I promise I'm not going to talk for 70 minutes. So I'll go over a few basic things about birdshot. And to be honest, many of you probably know this better than most of the physicians that treat retinal diseases. But as you know, it's strongly associated with this gene called HLA-A29. It comprises about 7% of all posterior uveitis. We talk about uveitis, that is intraocular inflammation, as being the front of the eye, the middle part of the eye, the back of the eye, or all of those levels together. And the differential diagnosis, that is the different diseases that tend to cause those different clinical patterns, depends in large part on where the inflammation persists. Birdshot affects the back of the eye, and therefore it's a posterior uveitis. It's very heavily geographically dependent. Many of you also know that birdshot is overwhelmingly found in Caucasians. I've rarely seen it in Hispanics. I've never seen birdshot in an African-American patient. And why that is, we don't know. Birdshot is most common in patients of Northern European ancestry. That gene has been sort of phylogenetically traced back to an area called Benelux, which is a little area that overlaps Belgium, the Netherlands, and Luxembourg. And I guarantee you that's the last time you're going to hear the word Luxembourg today. So we tend to see much more of it in North America than you might see in Central or South America, for example. The average age of onset is between 50 and 55, although there's a fairly wide range there. And it's a blinding disease in the absence of immunosuppressive therapy or other aggressive therapy. There's a small percentage of patients with birdshot who seem to do very well, but that's a very, very distinct minority. So most patients who get birdshot, this is a vision-threatening disease, and early treatment is particularly helpful. What are some of the symptoms of birdshot? I'm sure that many of you have experienced some or perhaps all of these. So nyctalopia, decreased night vision, For example, a patient may come in and say, when I ask about their vision, they say, on the eye chart, I see fine, I see 20/20, but I go into a restaurant at night and the restaurant's sort of dim, I can't read the menu. Or I take my dog for a walk around the block, and I hate doing it in the winter because by 4:30, it's dark outside, and I can't see the sidewalk. I'm afraid I'm going to trip. So decreased night vision is common, and it is the one symptom that is most associated with a decreased quality of life in patients with birdshot retinopathy. Floaters are common, sometimes flashing lights, what we technically call photopsias. Decreased contrast sensitivity. Patients will often say, I'm okay with my vision if it's a bright sunny day and I've got good contrast there. If I'm reading something, if it's black print on a white background, I'm pretty good. But if I'm picking up a magazine and it's glossy blue print on a glossy blue background, it's really hard to see. And many patients will describe this sort of non-specific, hard to describe vibrating vision in the eye. So I've said it comprises about 7% of all posterior uveitis, and posterior uveitis only comprises 7 to 20% of all uveitis total. Uveitis is not that common, so if you kind of do the math, overall birdshot chorioretinopathy accounts for about 1% of all patients with uveitis in the United States. And if you again do a little more math, in the United States that works out to about 1 per 100,000 population. So it's not very common. Now, the overall proportion of patients who carry that gene, that HLA-A29 gene, about 1 in 100,000 get birdshot. So most people who carry that gene, which in the US, in the Caucasian population, is about 7% or so of the population, most people never have any problems whatsoever. So that gene is critical in having a risk for developing birdshot, but having that gene doesn't mean you're going to get it. And that's important from a genetic or inherited basis for birdshot, because half the patients or half the offspring of somebody who is HLA-A29 positive are going to carry that gene. So everybody wants to know, what do I need to tell my children or my grandchildren? Are they at risk? And the reassuring thing is that, yeah, the HLA-29 certainly increases the risk, but statistically, very, very unlikely. We generally don't see patients with birdshot who have a family history of birdshot. So there's a number of studies that have been over the year trying to classify birdshot chorioretinopathy, what we call the diagnostic criteria. And this paper was published in the American Journal of Ophthalmology in 2021, was a series of uveitis. They had actually 2 separate issues of that journal. This is one of the major ophthalmology journals. 2 separate issues that talked about nothing but diagnostic criteria for different types of uveitis. And they had a group that was specifically designed to look at birdshot chorioretinopathy. The group was called the Standardization of Uveitis Nomenclature, or SUN working group. And this is a group of uveitis experts. They broke us down into different groups for different types of uveitis. In this particular case, they looked at 207 cases of birdshot chorioretinopathy that everybody in the group agreed. The multiple uveitis experts all agreed this is clearly birdshot. There's nothing else that this could be. And then they used machine learning to try to develop a parsimonious set of criteria. That is a small number of diagnostic criteria that you look for to minimize the risk of misclassifying birdshot as some other type of uveitis. It might be infectious, it might be inflammatory, like sarcoidosis. And that process created what they call a training set. And then the group of uveitis experts went through a process where they had to have a 75% agreement from everybody in that group to use one of those criteria or any of those criteria in making the diagnosis. And that created what they call a final validation set. And then they looked at that validation set and compared it to those classic cases to make sure they weren't missing something. And when they put all that together, this was what they came up with. And I'm sure that many of you have seen, those of you who have birdshot or have family members and you go with them to the doctor's office, you've seen these pictures that they take. So a characteristic appearance of what they call multifocal choroiditis. The choroid is a layer that's just deep to the retina in the back of the eye. So it has to be 5 spots or more. Single spot doesn't do it. They're oval or round. They're cream colored or often yellow-orange. They have a very characteristic appearance to them. When birdshot was first described by or first named by a physician at Hopkins in, I think it was 1980, he was a hunter on the Eastern Shore, and he thought that the appearance of these yellowish lesions in the retina looked like buckshot that was sprayed out. So in contrast to many ophthalmic conditions that affect the retina, sarcoidosis, for example, another common cause of uveitis, tends to have round and discrete lesions, and these are yellow. They have a different color to them, and so he called it birdshot. There's a little bit of inflammation in the gel-filled part, which is called the vitreous in the eye, and there's a little bit of inflammation in the very front of the eye. But in contrast to other types of uveitis, where those anterior chamber or vitreous inflammatory processes are much more fulminant, this is a little bit, but it's what accounts for the floaters that most people who have birdshot describe. So that's one way to do it. Or you can simply have multifocal choroiditis, those lesions, with a positive HLA-A29, and either characteristic findings on something called ICG angiography, one of the dye tests that I'm sure many of you have had, or the classic birdshot spots. So technically, you don't have to have a positive HLA-A29 to make the diagnosis of birdshot. You can be diagnosed on the upper set of criteria here. So the characteristic lesions with just a little bit of inflammation more toward the front of the eye. So these are here the classic birdshot lesions. They have that yellow appearance. They tend to start initially just below or inferior to the optic disc, which is here. The optic disc connects all the nerves from the retina going back into the brain. Here's what's called fluorescein angiography. I'm sure you've all had this. Fluorescein angiography is a dye that circulates through the blood vessels, including the blood vessels in the back of the eye. And normally you shouldn't see these spots that look sort of fuzzy in the blood vessels here. And that's characteristic. And this is a different type of angiography. This is the ICG angiography. And you see these multiple gray spots. We call these hypofluorescent spots. And those are characteristic for birdshot. Of those of you that have birdshot, how many of you have had both ICG angiography and fluorescein angiography? Yeah, so ICG angiography isn't used that commonly in retina practices, but birdshot is one of those things where it's very commonly used. We find it very helpful. And particularly in cases that are subtle, that may not fit into a well-defined birdshot, doing ICG angiography can really help you make the diagnosis as an ophthalmologist. All right, so all of you are familiar, of course, with OCT imaging. You've all had this. We'll have a quiz at the end of this talk on the layers of the retina. If you don't get at least 75%, you have to give back your T-shirts. So we'll do that. So this is a normal OCT, and there are a couple things that I just wanted to point out. This little divot right here, that's the very center of the retina. There's no blood vessels in the very center of the retina, and as a result, the retina is thinner in that area. So you have that normal, it's called the foveal pit. But I just tell my patients, that's just a divot. And in this case, divots, unlike your golf game, divots are good. Then you can appreciate the different gray and white and black lines that run horizontally here. Those are just different layers of the retina, but they're very discrete here. And in particular, there's a layer out here that runs horizontally. And if you think of the retina as a camera, not an iPhone, so only patients above a certain age appreciate this, but back when cameras actually had film in them, think of that layer out here as the film of the camera that is your eye. So if the front of your eye has, or the front of the camera rather, has the most expensive Nikon lens on it, and it's, a multi-$1,000 camera, but you put bad film in it, film that's out of date, you're not going to get a good picture, right? This area of the retina here contains the nerves, what are called the photoreceptors, that turn light into electrical signals that get processed through the retina and the optic nerve that go back into the eye. So when you have damage to that particular area, you don't get a good picture. And here's a patient who's got severe birdshot retinopathy. And you can see a couple of things here that I've highlighted in the air. So one is the loss of what we call the retinal laminations, these discrete areas, discrete layers of the retina. And then out here, rather than this triple white line that you see here in the normal OCT, it's sort of one smudged single line. And when you see that in a patient who's got birdshot, you know it's been long-standing, you know it's probably been undertreated. So our goal is to get patients when their retina on the OCT looks a lot more like this and a lot less like this. My former boss, when I was at Johns Hopkins, used to talk about birdshot as being like if you are on one of those classic windy, rainy cliffs in the UK. And you can walk down the edge of that cliff, and there's a stairway, and there's a railing to hold on to. And as long as you can hold on to that railing, you can at any point say, it's too wet, it's too rainy, it's too windy, I'm gonna go back up. And you turn around, you go back up, and you are right back where you started, and everything is good. If you are too adventurous, and you go down that, and you lose your grip on the railing, and you fall over the edge, you're not coming back. Everything is lost, right? And he described that's how birdshot can be. So back in the days when people didn't recognize birdshot, and patients would have a little inflammation in the front of the eye, and they got treated with steroid drops, or maybe some steroid pills, but the steroids caused side effects, so the patient stopped them. They didn't get treated with immunosuppressive therapy. He likened that to walking down to the edge of that cliff, losing your grip on the railing, and falling over the edge. You're not gonna come back. Whereas going down those steps was sort of, yes, you can have some early loss of vision in birdshot, but if you get treated properly, it's like grabbing back onto that railing and walking back up. So that was the analogy he always used. If you get to this point, the chances are very, 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 very poor that you're gonna get that vision back. So the key, and Dr. Thorne is gonna talk much more about this, the key in birdshot is early detection and early treatment. It's often hard to tell that to patients when they come in, because most patients who might have been told they have birdshot, or more precisely, more commonly, they're just told, you have uveitis, you should go see this doctor. So they come in to see Jen or see me or somebody else who recognizes birdshot, and they don't have a lot of information about it. And so we do the exam, things look like birdshot, we don't need an HLA-A29 to recognize classic birdshot. And all of a sudden, we're talking to patients about putting them on this poison, this immunosuppressive therapy for 2 or 3 years at least, because most patients who are on birdshot get treated for at least a couple of years, and in many cases, much longer than that. And of course, their eyes bug out, and like, I have a few floaters, what are you talking about? But those are the patients in the long term that do best. And that's part of what we'll talk about in a moment. But that's really part of the key aspect of treating birdshot is getting treated early, getting the disease recognized early, getting diagnosed early, and getting treated early. Those are the patients, at least in my experience, that are most likely to be able to come off therapy after 2 or 3 years and not have recurrence. One of the most common causes of vision loss in any type of uveitis, but including birdshot, is something called cystoid macular edema. So if you remember the normal appearance here of the OCT and that divot, and there's no black spots here, this image is just retinal atrophy. That's just long-term inflammation of the retina. But we see here, this is much more reversible. The dark spots that you see here and a little bit under the retina right there, that's the macular edema. That shows up on the OCT image, which is a standard thing. Everybody gets that now. That is a common cause of decreased vision. If you think of that retina as a sponge, normally the sponge should be dry. If you dip your sponge in water, it gets thickened, right, as it swells up. When the retina gets swollen, you lose vision. And this is a patient who had intravitreal steroid injections to treat that macular edema. Now, typically, steroid injections by themselves aren't the best way to treat macular edema, or to treat birdshot, I should say. But they can be very helpful as adjunctive therapy. This patient was already on immunosuppressive therapy, but they still got swelling. And then you see after the injection, this is just 3 months later, that retina looks a whole lot better. And correspondingly, her vision got much better. And this patient was particularly interesting because she is one of the few patients that I know who, she had a sibling who's got birdshot retinopathy. As I mentioned, we don't generally see that. Sometimes birdshot's really subtle. It's not an easy diagnosis to make. So patients come in with those symptoms. They might have the decreased night vision, the nyctalopia. They may have floaters. They may have some of the other things. But on the exam, you can't really see anything. And as a uveitis specialist, we know that patient symptoms are really critical. That will sometimes make the diagnosis for you, not so much what you see on the exam. So here's an eye. This is the patient's left eye, and it lacks all of those classic Birdshot lesions. It looks pretty normal there. But if you do an angiogram here, this is a fluorescein angiogram, you can see little areas where there's just a little bit of leakage there. So it looks fuzzy, sort of right in that spot. And this optic nerve here normally shouldn't take up the dye and look white. It should look gray. So that would be a tip-off to anybody who sees uveitis patients. There is clearly something going on here in the back of the eye. And in that patient who fits the right demographics, so 50-ish Caucasian, women may be a little more likely to get birdshot than men, but it's not so much that it really makes a difference diagnostically. But when they fit that criteria, that's when you start thinking, all right, I have to keep birdshot in mind, and they're going to go off and get their HLA-A29 testing. Now, there's other things that we can use to assess birdshot. Some of this is helpful diagnostically. Some of it is helpful prognostically. That is, when the patient has the disease and they start a treatment, how do you monitor the effectiveness of that? Again, Jen will talk more about this. But these include things like visual field testing. Visual field testing picks up it's kind of the EKG of the electroretinography, sort of the EKG of the eye. It evaluates the electrical activity of the retina, and that's diminished in birdshot, and you can use responses or improvement versus worsening in the ERG to see how a patient is doing on medication. The visual field testing helps to pick up peripheral vision loss. The usual visual fields that people get for, say, glaucoma mostly focus on the center 30 degrees of the eye. Most of the vision loss early on in birdshot is farther out peripherally. So they often do something called a Goldmann visual field. How many of you have had a Goldmann visual field? So a smaller number than have had the ICG testing. And some studies suggest that serial testing with that visual field test, measure the peripheral vision, can be helpful, again, to assess how a patient is responding. There are patients that have pretty significant constriction, and with effective treatment, that visual field gets bigger. And the patients will often notice that. They'll say, it's easier to drive. I can see cars coming up on my side that I couldn't see before. Fundus autofluorescence is just another imaging technique, non-invasive technique that will highlight some of the scars. And then finally, contrast sensitivity charts. Many patients with birdshot will notice that if, like I said, the contrast is good, if it's sharp black print on a white background, I'm fine with that. But if it's not that same contrast, I really struggle. And there are specific contrast sensitivity charts that are designed to assess, if you've ever seen a contrast sensitivity chart, on any given line, the letters are the same size, but the density of that color is less and less as you go from left to right. So on the darkest part, they may see 2040, but if you say, look at the right side where the contrast is a lot less, they might see 2200. All right, and again, I'm not going to steal Jen's thunder, but I mentioned there are a few very small numbers of patients who don't need treatment. I almost always recommend patients start on treatment because you never know who's going to be in that small category. Regional steroid injections that can go in the eye or around the eye can be helpful for things like macular edema. Again, they're probably not the best long-term treatment, and they have risks associated, including cataract and glaucoma. Oral steroids can be effective initially, but they're not a good approach long-term because we know that birdshot is one of those conditions where steroids can help, but only at doses of steroids that are just not feasible in the long term. How many of you take prednisone or oral steroids for your disease? And if you don't mind me asking, how much do you take?
I started with 60, 40, 20. I'm down now to 2.
Okay. How about the other people that raise their hand?
7.5.
Okay. Someone else?
3.
Yeah. So it's generally considered that 7.5 milligrams of prednisone is what we call a quote, safe dose. There is no safe dose of prednisone. I've been on prednisone 5 milligrams a day for the past 10 years. And despite religiously taking my calcium and vitamin D, which you should be taking if you're on any dose of prednisone, I still developed osteoporosis. So there isn't really a safe dose, but that's generally considered a dose that might be okay to take. Unfortunately, most patients in Birdshot, and those of you that are on prednisone, are you on immunosuppressive therapy as well? Yeah, so rarely is prednisone long-term a viable approach, because most people with Birdshot who are on prednisone will respond initially, but when they drop down to 15, 20 milligrams a day, the disease tends to flare up, and that's not a tolerable dose that you can take long-term. And as a result, most patients who are on Birdshot are on one of a variety of immunosuppressive regimens. I always joke, because I'm on immunosuppression myself, I always joke that I literally get a taste of my own medicine every day, because I understand when patients say, you know, that CellCept, man, that just upsets my stomach, and tacrolimus, I get a tremor, I don't like it. So I'm very sympathetic to that. Many patients are on more than one medication. It might be low doses of steroids and immunosuppressants. It might be a couple of different immunosuppressants. It might be an immunosuppressant with repeated or long-term steroid injections. But there's no randomized controlled clinical trials of Birdshot per se. There's a big study, and Jen will probably talk about this, called the ADVISE study, which looks at a number of patients. What's the N in ADVISE? 200? Yeah. So some are a little over 200 patients that are randomized to treatment with what we call conventional immunosuppression. Things like cyclosporin, tacrolimus, mycophenolate, which is CellCept, or methotrexate, compared to adalimumab, which is one of the so-called biologics. For the, how many people are on immunosuppression for their Birdshot? So a good percentage. And how many of you are on a biologic? So again, big percentage. How many of you are just on conventional immunosuppressants? So a smaller number, yeah. So anyways, that study has finished enrollment. It's in the data collection phase. And the idea on that study is Humira, or adalimumab, is that more effective than conventional immunosuppression? But ADVISE covers a lot of people with different types of uveitis, not just Birdshot. I don't know the N of Birdshot in there, but it's going to be small. So it's not going to tell us a whole lot about Birdshot per se. And there's no specific reason why somebody who's got Birdshot retinopathy versus sarcoid-associated uveitis versus one of the other so-called white dot syndromes, there's no reason to think that they have to behave the same way. That if somebody with sarcoid responds to a certain medication, then all patients with uveitis should respond to that. It doesn't hold that way. So that's going to be really helpful, but it's still not going to tell us enough about Birdshot in and of itself. So we really need to try to get some trials of Birdshot by itself. This is one of the long-term implants here. It looks like somebody dropped a cigarette butt inside the eye, but that's called a YUTIQ. That's a long-term fluocinolone acetonide implant that's designed to last for 2.5 to 3 years. So again, in combination in most cases with immunosuppressive therapy, this is something that can help prevent recurrences of macular edema. That's what I use it most commonly for. So the first Birdshot Day was held in the UK in 2010. There were 76 patients and supporters there, about the same number that we've got here today. A lot of them were health professionals. They wrote this up in the British Journal of Ophthalmology a few years later in 2013. And they listed their goals in that initial meeting as they wanted to reduce the sense of isolation of patients who have Birdshot. They wanted to raise the profile of the disease. They wanted to allow for a good two-way exchange of information between patients and their care providers. They wanted to obtain better visual outcomes. And they wanted to provide a base for research. And this turned out to be incredibly effective. And I can tell you overall that the infrastructure in the UK for Birdshot is a whole lot better than the infrastructure in the United States is for Birdshot. So one of the things that they asked the patients, they did a survey after this was all done, and they said, assuming there is no cure, what is the single factor that would improve my quality of life the most? And they asked that of all of the patients with Birdshot who attended. And overwhelmingly, the most common was fewer drug side effects. For those of you that are on immunosuppression, how many of you have 0 side effects? Yeah. So 100% of patients have side effects, and hopefully they're tolerable, but everybody has side effects. And then other things. They wanted more frequent, more detailed monitoring. For about 10%, it was practical or financial support, unless some of you who are on Humira have been one of those billion-dollar lottery winners. I'm assuming you're not paying for your Humira out of pocket. It's very expensive. About 5% said emotional support. We have a tendency in medicine to, as non-affected people just out there in the world, you tend to be a lot more sympathetic to someone who has a visible problem. Somebody's in a wheelchair, somebody uses a cane. If somebody doesn't have visible problems, if they don't have the dark glasses that a lot of patients who are blind wear, most people don't think of them as disabled. Like, well, you're outside, you're walking. I'm not going to offer assistance when you're trying to get up those stairs or something like that. So for a lot of people, that lack of sort of emotional understanding, not just from strangers, but even from family members sometimes was important. And then there were a variety of other things that patients had as their single biggest factor that impacted their quality of life. So within 3 weeks after that first meeting in the UK in 2010, was held in London, the number of hits on the Birdshot Uveitis Society website more than doubled, up to 67,000. 97% of participants, that is the patients, and 88% of professionals said they would come again next time, and they've held subsequent Birdshot meetings. 100% of the professionals said that they would recommend the session to their Birdshot patients if it were held again, and 96% say they would recommend it to their colleagues. So by all these criteria, it was an enormous success. We would love to have similar feedback from participants today. 100% of patients said they would give blood as part of a research project. I'm not really going to get into this, but I did mention that essentially everybody who has Birdshot has a positive HLA-A29. Have all of you with Birdshot had HLA-A29 testing? Yeah. And are any of you HLA-A29 negative? So no one fits into that category. So a positive test isn't generally critical to make the diagnosis, but if you have retinal vasculitis, if you have posterior uveitis, and you are negative for HLA-A29, you have pretty much 100% chance that you do not have Birdshot. So a negative test for that is much more important than a positive test. But again, most people who carry that gene don't have any eye problems. They don't have any problems at all. So there are clearly other factors, and what's not known is that another genetic factor? And maybe over time, there'll be studies that look at markers in the blood, and maybe they identify something else. Or maybe it's environmental. So, and then finally, one of the major upshots of that UK meeting was that the Birdshot Day led to the creation of a national Birdshot research network, which is a nationwide partnership of patients, uveitis specialists, other healthcare providers, scientists, physicians, nurses, along with patients. And it was incredibly successful. We don't have that degree of infrastructure in the States. One of the things that I would hope to get out of this meeting today is taking those steps to start increasing the awareness of the disease and promoting exactly what they did over 10 years ago in London. So as I mentioned, they've had other follow-up meetings, 2018, 2012. We had the meeting here, 2019, and that was more low-key. It was there. They had some talks on clinical research. They disseminated a lot of information about low vision, which is critical. They talked about support groups and talked about the organizational structure of the North American Birdshot Uveitis Society. So it was very helpful in that regard. That's come a long ways. Christine gets an enormous amount of credit for kind of spearheading that, but there are a number of people that have been active in that. As I said, this is the reference for those of you who wanted to look in the British Journal of Ophthalmology. So now they have the Birdshot Uveitis Society of North America, which is a 501c3 organization. It was established in 2020, so it's a young group. It's registered in the state of Pennsylvania. There's a board of directors that's involved, and it collaborates with several other Birdshot groups to share resources and patient experiences. These are the members of the BUSNA board. So if you see them today, tell them thank you for their work. And this is the advisory board. I'll single out Meredith Cross herself because not only is she a member of the advisory board, but she has funded the chair of the professorship that Dr. Thorne holds at Johns Hopkins. So one of the points that was made in that British Journal of Ophthalmology article in 2013 was that it is already clear that what is important to clinicians and researchers may not be the important thing to patients with eye disease. So we as physicians, we tend to focus on how is your vision? Oh, you saw 20/30 today. Last time you saw 20/40. That's great. Everything must be wonderful. You're getting better. Those of you that have Birdshot know that's not how it works. Sometimes your vision on the eye chart in a dark room with sharp black letters on a white background, sometimes that correlates with how you're functioning in the real world, but a lot of times it doesn't. But we tend to focus on criteria like what is your Snellen visual acuity? What is the thickness of your retina? Because we can measure that. We can say last time your central subfield thickness, the thickness of the retina in the very center where your sharpest vision originates is, today it's 350 microns, and last time it was 450 microns. So that steroid injection did great. That made a huge difference. It's good to know that, but many times the patients, that's not what they care about. They care about what is my function, what is my quality of visual life, what is my overall quality of life. And what I wanted to finish up with for a bit now is to talk about what are known as patient-reported outcomes measures. So this is getting back much more to what is important to patients, not so much what is important to physicians. Ideally, those two things would overlap quite a bit, but as physicians, we sometimes don't take those patient reported outcomes as seriously. And part of that is, as physicians, we're taught to measure what we can measure. Something has to be, there has to be a number. Your retinal thickness is 278 microns today. That's better than it was before. If it's 20% less than it was the last time, that's what we call evidence of a clinical response to treatment, steroid injection, or immunosuppressive therapy. And we tend to say, we can't measure things like, I have trouble walking my dog at night because I can't see the sidewalk. And sidewalk in my town is bumpy, and I'm afraid I'm going to trip. I don't really drive at night anymore. I'm not comfortable driving. Those we don't think of as measurable things, but that's the essence of patient-reported outcomes measures. What matters to the patient? And a big part of that is quality of life. There are a lot of things. Patient-centered outcomes research has exploded over the last 10 or 15 years. And in pretty much any field of medicine, you'll be able to look up those things. When I looked up, I just Googled patient-centered outcomes research, and there were 9,300 hits that came up. So I just listed some of them here. There's one on outcomes in bladder cancer. So you can imagine somebody who has bladder cancer. To the physician, it might be, oh, your PET scan shows no evidence of metastases. That's great. Or when we did your biopsy, we didn't find any recurrence of the cancer. Whereas the patient is thinking, it hurts to pee, or I'm peeing all the time. That's the difference between what doctors tend to look at and what matters to patients. There's a lot of outcomes measure research in pediatric conditions. The one at the bottom is on patients who have Parkinson's disease. And again, you can measure lots of things objectively in Parkinson's. So you can measure, for example, in the eye, patients who have Parkinson's have a decreased blink rate. They tend to get really dry eyes. You could measure the blink rate. But to the patient, it's, well, my eyes just hurt. What are you going to do about that? So those are the things that outcomes research should be looking at. There's certainly many things in ophthalmology as well. There's one, retinoblastoma, which is an eye cancer found in children. There's one for the ability of vision-challenged pediatric patients, how they develop and adapt. And there's a few specifically related to uveitis. So there's one here on juvenile rheumatoid arthritis-associated uveitis. one on patients with uveitis or scleritis in general, and then some other ones about how you can set up one of these programs. And that's what I would like to get out of this meeting today, on the creating a listserv, people that are interested in this. How can we go about creating better patient-related outcomes measures for patients with birdshot retinopathy? So when physicians look at things, again, they look at things like survival. You have cancer, we start you on a new, what they call a checkpoint inhibitor, one of the new immunotherapy drugs that everybody has heard about in the lay press. It's what's allowed Jimmy Carter to survive from his metastatic melanoma. So, survival in this cohort of patients that got treated with new treatment A, their median survival went from 2 months to 4 months. Now, is that helpful? Sure. Now, you've doubled the lifespan. Is 2 months to 4 months if the side effect of that medicine is basically around the toilet 24/7 from diarrhea or vomiting? Has your quality of life gotten better? That's not measured in just assessing survival. We look at things, as I mentioned, like visual acuity. We look at OCT and fluorescein angiography and visual fields, ICG angiography, all those things. And all those are important. But what the patient wants to know is, how is this going to impact my quality of life? And if I could just throw it out to the audience, for those of you that have been on immunosuppressive therapy for your birdshot, how many of you, I know this is very arbitrary, but how many of you would say that your quality of life based on your visual function has substantially improved? So certainly some, okay, but not everybody. And as one author said, one of the key things about patient-related outcomes measure studies is finding the right treatment for the right diagnosis at the right time for the right patient. So many of you might be on Humira. Great, but some of you have side effects from Humira and they can't take it. Well, what's the best medicine? Or if you got started on methotrexate or mycophenolate and you had side effects, what's the outcome there? When I had my heart transplant and got started on the immunosuppressive therapy, they mentioned that one of the potential risks of mycophenolate is skin cancer. It wasn't a big part. I mean, I was concerned with am I going to live to see my daughter get married? And I've done great. This was 10 years ago, so I've done very well with the heart transplant. But I stopped counting when I got over 20 skin cancers. And by the criteria of the transplant group at Penn, I'm out there. I'm like one of the outliers. My goal in October to celebrate the 10th anniversary of my heart transplant is to climb Mount Kilimanjaro. So they're like, man, you're doing awesome. This is great. They generally don't ask about how my skin cancers are doing. And I've been fortunate. I've never had a melanoma. It's always been basal and squamous cell. None of them have spread or anything. There's a big chunk of my scalp that's missing from one of those cancers. So for me, I see my dermatologist more than I see my transplant doctors at this point. And for me, I live in fear of getting melanoma. And finally, the transplant doc said, you're far enough out, we're going to stop the Cellcept, at this point, the mycophenolate. So I'm still on tacrolimus, I'm still on a little bit of prednisone to protect my kidneys. But I've still gotten more skin cancers. And I see my dermatologist, my dermato-oncologist, like every 3 months. So to me, that's, what's critical. The transplant team is ecstatic when I have my yearly MRI of my heart, and I go through my cardiac echo, and they say, yeah, you're doing great. Come back in 6 months, we'll repeat the echo in a year. But I've got other things that I worry about, and I'm sure those of you that have birdshot have the exact same thing. Your doc may be saying, things look really good, but you may have other concerns. And I would emphasize that whether it's part of a study or not, making sure that your physician understands your concerns is really critical. Doctors are generally not so good at listening sometimes. We all have a lot of patients we need to see. But if you have a particular anxiety, like I know you say the Humira is working well for me, but I'm terrified that my mild heart failure is going to get worse because that's a potential side effect of Humira. So make sure you bring those concerns up with your doctor. So this sounds a little bit too medicine-y here, that first one, but the goals in the patient-related outcomes measures is to get an interval scaled measure for each quality of life domain that is measured. What that means simply is you'd like to be able to quantify patients' complaints. How do you quantify, I have trouble seeing at night? How do you quantify, I think my floaters are worse? And you'd like to be able to do that in some measurable outcome that's scaled. You know, it might be on a 1 to 5 basis or a 1 to 100 basis, whatever it is. You want that measure to be targeted to the construct of interest. So if you are evaluating somebody at a heart transplant, your measures of concern the patients can have are going to be different from those that have Birdshot retinopathy. We want to be able to facilitate the subjective impact of both the disease and the treatment. How do we quantify what it means to have Birdshot? How do we quantify what it means to be on long-term, in some cases lifetime, immunosuppressive therapy? And eventually we want to be able to incorporate these outcomes measures into clinical trials as a primary outcome measure, not just if you have a reduction in your retinal thickness of more than 20%, the study was a success. And increasingly now, studies of uveitis patients and other studies in medicine, but specifically for uveitis, now those outcome measures are starting to become just a standard part of clinical trials. And those include things like quality of life surveys that helps to pick up side effects from medications. Yeah, my Birdshot's better, according to the doctor, and my visual fields have expanded, my electroretinography images show better waveforms, but I'm on the toilet 24/7. You know, that would come up in the quality of life surveys. There's something called what we call the VivQuack, the visual field quality, and there's 11 related measures of that. So when we talk about vision, normally you say, well, my vision on the eye chart was okay, but my night vision's terrible. Or I see okay far away, but reading is really a problem. Or I can't watch TV. How do you pick that up? Well, these tests are designed to measure just that. So it looks at near vision, looks at distance vision, looks at peripheral vision, looks at color vision, looks at contrast, assesses pain, social functioning. You know, can I go out and go shopping by myself? Am I able to do that? Ability to drive, mental health questions, dependency levels. I guess I see okay on the eye chart, but I don't feel ever comfortable going out on my own. I need a family member or friend to take me to the grocery store because I just can't see well enough to pick things up. So these are the types of things that are more and more getting incorporated into different studies. So what we'd like to see specifically as far as Birdshot, we'd like to have larger numbers of Birdshot patients taking part in clinical trials. I would love to create an online cohort of patients who are interested in promulgating this type of patient-related outcomes measures when we do research, and has already been done in large part to the people that set up BUSNA, is to create this bigger and bigger forum for patient awareness and referrals. So they get diagnosed early, they get treated early, and hopefully have better outcomes. So some special thanks to Christina. I can't say that I've done a whole lot for her vision at that point, but I love having her as a patient. Jack Scully came in on his day off to do this. And to everybody in BUSNA that's helped make that successful, and to Wills Eye Hospital. So I hope you have a great day today. Good. Definitely under an hour and 10 minutes. So are there any questions that came up from this talk? If it's a question about treatment, let's defer that until Jen talks. Yes?
I have a quick question. I was diagnosed 6 months ago, and I keep hearing Birdshot is thought to be an autoimmune disease. Can you elaborate on that?
So we try as physicians to make ourselves look smarter than we are. So you've also probably heard the term idiopathic. Idiopathic is a fancy way of saying the cause is unknown. But if we say, well, we don't know what causes it, patients are unimpressed. We say, oh, you have idiopathic uveitis. It's like, wow, this dude is really smart. And I think the term autoimmune kind of gets used in the same way. If we are confident that it's not infectious, if it doesn't fit into certain other criteria, by default, we kind of call it autoimmune. But we could just as easily say, well, it's a genetic disease. You really have to have this HLA-A29. But that is also insufficient because, as I said, having HLA-A29 only means you're more at risk, but it certainly doesn't mean you're going to get birdshot. So autoimmune diagnosis is kind of a wastebasket term. I mean, it had different contexts to a PhD in immunology, for example. But to me, as a clinician, it's just, it kind of tells us that we've been able to rule out certain things, certain infections, or certain types of specific other diseases like sarcoidosis. But beyond that, and then prognostically, it kind of tells us when you have an autoimmune disease, you generally need immunosuppressive therapy. So if that helps. Yeah, somebody else had a question.
Hi. I have read a study that, and I feel in my case, for Birdshot, it was the same thing, but I read a study, there was a study done on multifocal choroiditis, and it was related to mold, that mold was the catalyst. I feel in my case, mold was the catalyst for Birdshot. I know there hasn't been any studies on that, but that's what I feel.
Yep.
And also, this is just an aside for yourself, I'm on a whole food plant-based diet, which I really feel is very helpful. And from my doctors, I learned that taking calcium, leaches calcium out of the bones, that it's not good to take calcium, but you should in food. I mean, eat healthy food, but not take a supplement.
I'm not a dietary expert. I have lots of patients that talk to me about diet, and is there, people are interested in anti-inflammatory diets. How much turmeric should I take is another common question. If economics is the dismal science, then food science is the dismalist science. There's so much nonsense out there because, in part, it's hard to quantify a lot of the things. People say, I feel better when I'm on a gluten-free diet. What does that mean? How do you measure that? Not that gluten-free diets can't be helpful in certain patients, but the point is we lack a good understanding of how diet and the gut, it's a huge area of research, but how all that plays into autoimmune diseases is being looked at.
Are you familiar with the multifocal choroiditis?
Yes, yeah, I remember reading that paper, and case reports are helpful in medicine because it allows people to maybe think in new creative directions. Oh, I read this report about mold. Maybe I should ask that when my patient comes in.
I was exposed to black mold and not that mold. Just one last thing. I've been in remission since 2006, and I was on heavy pred and cyclosporin, which of course is debilitating.
So case reports are helpful, but they're not anywhere near the same as a controlled clinical trial. A good example of that would be tattoos. Most people have Birdshot are a little bit older, so I don't know. How many of you have tattoos? There we go. And you look young. But it's something like 30% of the population under the age of 30 is estimated to have tattoos. And there's a condition called tattoo-associated uveitis that is only in the last 10 or 15 years start to have been recognized as patients that have tattoos, they get itching and thickening of the pigmented part of the tattoo, not the adjacent skin. So it's very specific to the pigmented part, particularly the dark pigments, so the blues and the blacks, and not so much reds or greens. And that can be associated with a uveitis that looks for all the world like sarcoid uveitis in its clinical pattern. And now asking about tattoos is a routine thing for me when I see patients with uveitis. So maybe in another 10 years I'll have a better sense, and a routine question would be, have you been exposed to mold? So right now it's sort of interesting, but we don't know what to make of it beyond that. Yes?
Lyme. How many patients are coming in with Lyme and ending up with Birdshot?
Right. So uveitis doctors have for a long time tried to put together big series of what they call ocular Lyme borreliosis. So inflammation in the eye associated with Lyme disease. And while there's no question that Lyme disease can cause lots of problems, and there's an enormous discussion that I won't get into about long-term Lyme and what does it cause and so forth. But as far as ophthalmology goes and uveitis goes, when people have tried to put together, say, oh, I got a bunch of cases we'll have 100 cases we'll put together, and we'll describe the wide range of findings that you get in Lyme disease in the eye. And when they started looking at it, they said, well, that wasn't really Lyme disease. And nobody's been able to put together a big study. So ocular Lyme disease is pretty uncommon. It's not unheard of. But personally, I think it kind of gets overestimated. And part of that problem is if you test people for Lyme disease, lots of people have positive antibodies to Lyme disease. That does not mean you have Lyme disease. It means you were exposed to it at one point. That's all. And
JP, son, they 77 international uveitis experts, and they found under 75 cases
Yeah.
of ocular Lyme
Yeah.
uveitis.
so Jen was just saying that, we had, when we did the Sun criteria for Birdshot, we had 207 well-defined cases. Jen was saying that among the 75 members of that standardization of uveitis nomenclature working group, less than one case per patient came up. So to get back to your question, the bottom line is we don't really know. Maybe it's multifactorial for Birdshot. Maybe you have to have that, what they call the second hit hypothesis. The first one is you have to carry that HLA-A29 gene, and then there's some other environmental factor. But maybe it's multiple factors. Maybe for some patients it's an infection. For other patients it's who knows what. So we don't really know. I can only say from my own personal basis that I virtually never will put somebody on treatment for Lyme disease, for example, doxycycline or ceftriaxone for Birdshot, because I just don't think personally it's a factor. But I am not what is known as a Lyme literate doctor, which is a big thing in Pennsylvania. So if that sounds too vague, I'm sorry. Yes? Nope, just behind you. I'll get back to you. One behind you.
A quick question. My symptoms are pretty much the same as everybody else's, but I don't hear often of people saying that they have pain. And I get jabbing pain if I don't drink my green tea. If I miss a few days, then I get a jab, and okay, I'm back on it. But I
So it's very, very clear that polyphenols you might get in tea cures Birdshot. No, I'm kidding. So again, we don't know. There's so many things. Yeah. What I tell my patients when they come up with something that I can't explain, which is probably 98% of the time that I get asked a question and I don't know the answer, I'll say, if it feels good, do it. So if I have a patient that says, I went on a gluten-free diet and my Birdshot got better, great. I can't explain that, but if it works for you, this is assuming that what they're saying is, I'm going to ingest, 25 ounces of benzene a day. I'm going to inject bleach in my body, to put another example. I would discourage patients from doing that. But if they say, I'm taking something that seems to help, power to them. Yeah. The fact that we can't explain it doesn't mean it doesn't help. Yes, your question. Yeah, no, with that, yeah.
Oh, okay. All right. You had mentioned men versus women. What about eye color? I would think blue
So
eyes
another-
would be more susceptible. but-
Another great question. I don't know that there's evidence along those lines, but again, there's going to be a lot of, as they say, confounding variables. So if it's mostly people of Northern European extraction that get Birdshot, there's a much higher percentage of blue-eyed people in that category. So I don't know, but that's one of those things that, as an example, in macular degeneration, something else that affects the center of the retina and is an enormous cause it's the most common cause of vision loss in Caucasians over a certain age. Blue eyes are a risk factor for that. I'm not aware of data that suggests that it's the case in Birdshot, but like many other things, time will tell. Yes?
What are your views on the COVID vaccine?
As a cause of uveitis, it clearly can occur. I think like most vaccines, you're weighing the risks and benefits. Personally,
The amounts are going up every year as they do more studies.
right. So the numbers are clearly low. The numbers are clearly not zero. the risks of side effects in a rare disease are hard to pick up. So you can have a huge clinical trial. You might have, 5,000 patients or something in a trial of a vaccine, and that number is not enough to pick up rare conditions. So as they say, the post-marketing surveys become critical. I think a lot of that is patient's decision. I mean, if I have a patient that I see who has developed uveitis after a vaccine, I usually say, don't get that vaccine again. But if you are at high risk for COVID, if you are older, if you have asthma, if you are immunosuppressed, what's the risk of uveitis versus the risk of getting COVID, and maybe long COVID? Many of those are unanswerable questions, and
I
there's
understand there's a new vaccine that just came out. that is
For-
comparable to the COVID vaccine, but not RNA.
there's several different vaccines.
I just read this.
Yeah. I'm not a virologist, and I don't know if that is going to really correspond to either better outcomes or fewer side effects. I know personally I've gotten all the COVID vaccines, and apart from the government now having access to my brain, I haven't had side effects. So for a sample of one, I've done okay. But yeah, it's very much a personal decision. Yes.
Have you ever found, speaking to patients, more on a casual basis, just anecdotally, that they come up with other common complaints, health complaints?
You mean specifically with Birdshot?
Birdshot patients, but I'm thinking maybe gastrointestinal or vestibular problems, or have you ever heard that?
I haven't, at least not the GI symptoms. Now, obviously, again, we get into confounding variables. So if you're taking prednisone and mycophenolate, your chances of getting occasional stomach upset are probably pretty high. Is that the disease or is that the treatment? It's hard to parse those out sometimes. But I think much like the question was asked earlier, maybe, vestibular stuff kind of makes more sense. But we don't know. That's why we need more research, and that's why we need patient-related outcomes measures. I will make a comment about vaccines. I heard a case the other day. Some well-known person was flying on a plane, and normally it would be a situation of someone would say, I don't want to sit next to somebody who's not been vaccinated for COVID because I'm at risk. This was a case of the patient refused to sit next to someone because that patient was vaccinated. And I had a lot of trouble figuring that out.
I just recently heard of a case of Guillain-Barré from the vaccine.
Oh, yeah. Any vaccine has been reported with Guillain-Barré. Yeah, very common. Somebody else had a question. Yes.
I saw one of the items up there, you said that it was heavily geographically dependent.
Mm-hmm.
What does that mean?
Just means if you are in a city, we might see less birdshot than in Philadelphia, because in the two places I've been on the faculty, in Baltimore and Philadelphia, very large black populations. I've never seen birdshot in an African American. If you are in, Labrador, Canada, where there's probably a whole lot of people that can trace their ancestry to the Benelux area, you're going to have a higher percentage. If you're practicing in Mexico City, you're not going to see birdshot. When I was a fellow in San Francisco, because there were a lot of Asians in San Francisco, there's a disease called Birdshot's disease, which is much more common in Asians. And I saw a fair amount of it in San Francisco. I rarely see Birdshot's disease here. So that's what I mean by geographically variable. Some behind, yes.
Isn't there a thing we as a Birdshot community and on BUZZNA as well do to help in some way with patient-reported outcome measures, which I agree is very, very important?
Yes, and as I said, one of the goals that I'd like to get out of this particular meeting is starting to develop some of those processes to see if we can do that, because BUZZNA's been so helpful, and there's such an expanding community compared to even 4 years ago, or 5 years ago, whenever we had the first meeting here. Much more awareness on the part of patients, a lot more interaction now. So I think just because of the electronic infrastructure now, we have the capacity to generate those numbers, and it's not just, well, one patient said that they had birdshot that they associated with mold exposure. You know, you can put a lot more of this data together to talk about, you know, vestibular changes or GI changes, and put out a survey. And maybe you find, oh, that's interesting, you know, 25% of our patients say they have vestibular changes. Nobody's reported that. Or it might be one person said they had that. But having bigger numbers is what we really need, and I'm hoping we can take advantage of the infrastructure that has been created for Birdshot to develop those sorts of things. You already asked the question. You only get one question.
I want to say something anecdotally, though. It's interesting because you said that UK was much more advanced, you know? But I just have to tell you, I was diagnosed first after being misdiagnosed, whatever. I was diagnosed in 2003, and I Googled my brains out, found nothing here, found something in the UK, emailed that person, then we formed an unbelievable relationship, and she sent me to Dr. Michael Sampson in New York, who worked with Dr. Forster.
Yeah.
From somebody from England sent me, which is amazing to me.
Yeah. Hopefully patients with Birdshot wouldn't have that much difficulty getting referred to someone now. But uveitis is a pretty small field. What's the American Uveitis Society has?
About 300
Two-
members,
yeah.
and about 40 of them are international members.
Yeah, so there's not a lot of
And
uveitis specialists
there are
around.
probably another 20 that are emeritus.
Yeah.
So I would say somewhere around 220, 230
Yeah.
that are actively practicing.
Yes,
Anything happening with stem cells and uveitis? Any studies there?
I like to joke that stem cells are the future of ophthalmology and always will be. So it's a great question. Again, a little above my pay grade. Stem cells have all sorts of potential in terms of fixing things, but it's an enormously complicated situation. It's not like, I use that analogy of the eye as a camera and Birdshot affects the film. It is not a simple question of putting in some new film. So there's all kinds of things that have to be fixed before that can take place. And again, a huge amount of research in that area. There's certainly lots of trials at this point using stem cells. Most of that is in what they call inherited retinal disease, where there's a known gene defect that they can either take out or put in to try to do it. But there will be a lot of talk about that. I think for those of you that are interested in stem cell research, when you start seeing articles or stories about people that have had spinal cord injuries who have had treatment with stem cells, who are able to use their limbs more, be able to walk, something like that, there's a lot of overlap between spinal cord injuries and retinal injuries because they're both parts of the central nervous system.
I'm on stem cell eye drops right now for 90 days, morning and night, so we'll see, I guess. But
Right.
I had a lot of tests before, we'll see if I do a lot.
Yeah. See, what we'd love to have for that, unfortunately, a lot of stuff in stem cells is case reports, it's people that don't publish, some of it is frankly bad science. I mean, you can go to Florida and for $25,000, they'll take out some abdominal fat, spin it down and inject it into whatever organ you ask them to do. And there's no scientific research going on. So who knows? Yeah. All right. Well, thank you very much. I appreciate the questions.